Now, the sciatic nerve is not small, and in a conventional sequence, you can see the nerve. It's just not very well differentiated from surrounding tissues, and it's difficult to make out some of the fine points of injury. But here you see the same image section, but with the neurographic sequence, with fat suppression, vessel suppression, and the long T2 used to suppress the signal from other tissues so that the nerve becomes the brightest structure in the image, the most conspicuous structure. Now, it is possible to follow the sciatic nerve all the way up to its takeoff in the lumbosacral plexus. At this point, high above the injury, it's not particularly bright, yet there's a conspicuousness to the nerve shown in this sequence because of the fine fascicle structure which you can make out, and that's a unique appearance that lets us follow the origins of the sciatic nerve as it emerges from the plexus. Now we can use this sequence lower down to continue to follow the nerve, but notice what's happening at the very bottom of the sequence, which is that at one side of the nerve, a portion of the fascicles have started to flash on bright. There it is. Up, and then as you follow it down, flash. That's the very top of the injury signal in the sciatic nerve. And shooting a little lower down, you can watch as the intensity spreads through the nerve. It starts just at one edge and then spreads through the nerve, reflecting the extension of the pathology among the fascicles in the area. It's not clear whether it's distributed sequentially as we pass down because of a vascular origin, the way the trauma was inflicted, or just the severity of the impact of the fascicles lower down. Now, going through the critical area of injury, you can follow the fascicles from the top here, and then as the peroneal nerve splits off, you see it. And then watch the fascicles. They're dark here, and they enlarge and brighten. And look in the peroneal component as we pass downwards. There's one particular fascicle that becomes particularly large, round, and bright, which is the one that can be seen as well in the projection. Notice there are numerous fascicles within the bundle which enlarge in size and become bright. You can see that the total size of the nerve changes very little, whereas the fascicles grow in size at the expense of the interfascicular epineurium, which remains dark despite the injury. With this portion of the nerve magnified, you get an even better view of what's happening with the fascicles. Note that at the top they're relatively low in intensity and fairly uniform in size. And then as we begin to pass down, you'll see them swell and brighten. And this is the fascicle compartment injury which we've been able to see with the neurographic technique, which is not possible to see otherwise. This also demonstrates the very high resolution that the phased array coils make possible. Now, because of the very high conspicuity of the nerve fascicles, we're able to do a maximum intensity projection that gives a full three-dimensional impression of the nerve. Here it's the sciatic nerve splitting into the tibial and peroneal components. And this allows us to rotate the nerve and examine it from all sides, and also allows for the observation of the course of the fascicles across and through the area of injury. You can see in the peroneal component a particularly bright portion of the nerve, one fascicle in particular, and this correlates with the brightest and largest fascicle at the main site of the injury that we saw in the cross sections. This is a patient imaged 2 years after a very severe traumatic blunt injury to a sciatic nerve, and it's a similar region to the other patient. You can see a more healed structure. The fascicles are larger and there are fewer fascicles, presumably because there's internal fibrosis within the nerve. You can also see how this kind of view allows you to follow the relation of the nerve to the femoral artery and vein as they pass into the popliteal fossa. It's difficult to follow the ulnar nerve through the elbow in many patients because the arm is off-centered in the imager. But here you can see a very bright ulnar nerve starting above the elbow and then passing right around the cubital tunnel. It brightens very significantly, and it's possible to follow it and distinguish it by its course from the vessels in the area. Using a three-dimensional FSE acquisition sequence to have three-dimensional equally sized voxels, it's possible to get a good three-dimensional rotation of the lumbar thecal sac and the lumbar nerve roots and the dorsal root ganglia as they come out from the sac. This patient has herniated discs at 2 levels, which you see impinging on the myelographic portion of the image. But you can also make out the nerve roots and see that the L5 nerve root is somewhat deviated in location. Looking more closely, again, if you watch the L5 root coming into view on the left, it's distorted and pushed upward from the line of the other roots. This is consistent with the traction caused by the herniated disc causing symptoms at the L4-5 level. This is a 30-year-old man with hand pain who had only very mild foraminal stenosis. Because of the high conspicuity of the nerves, we can see on the individual sections that one of the nerve roots is brighter than the others. But again, because of the high conspicuity, it's possible to do an overlay projection and to look at the assembly of the entire structure of the cervical roots as they emerge from the spine. And here you see the entire image assembled by overlay, and you can count the nerve roots, identify the level, and clearly see the remarkable hyperintensity of the C5 cervical root. Here you can see the dorsal root ganglia at the emergence of the nerve roots, and again, the very bright intensity of the involved root.